Good evening, friends, and thank you for being here on the second day of the ENDIAB Summit 2021. I know that I'm standing between you and dinner, and well, I would be talking about the future of GLP-1 RA therapy, which would perhaps limit your intake in dinner. Well, these are a few customary disclosure slides, and I have been commercially supported by Novo Nordisk, but I do not have any actual or potential conflict of interest in relation to this presentation. So today, our topic says the future of GLP-1 RA therapy. Well, we had the first drug, insulin, and incidentally, this is the 100 years of insulin discovery. Then we had sulfonylureas in 1960, metformin in 1980, approved in USA in 1998, 99. Then we got alpha glucosidase inhibitors, rapid acting insulins, that's analog rapid acting, basal insulin, TZDs, meglitide, GLP-1 receptor agonists, pramlintide, DPP-4 inhibitors, bromocriptine, SGLT2 inhibitors, all falling into queue. And we have had a plethora of guidelines coming in. 2016, 2017, you had the ADA as well as the ESC joining in. 2018, the ADA, ASD, the JAC publishing the ACC decision-making pathway. Then you had 2019, the ACC AHA again, the ESC, and you had the 2020, the consensus report update, the ESC ASD joint statement, and the standards of medical care from ADA. So the last century has seen an explosion of the available drugs and plethora of guidelines for the management of type 2 diabetes, which is predominantly an accelerated rate in the last 20 years for the drugs and for the last 5 years for the guidelines. Despite availability of so many numerous treatments, diabetes management remains a challenge. It remains the 9th major cause of death globally, and 50% patients with type 2 diabetes present with microvascular complications, 27% present with macrovascular complications, and 25% have diabetic kidney disease. The menace is huge for India. The burden of diabetes in India is absolutely humongous. The India ranks second worldwide in terms of number of adults with diabetes, and out of 88 million diabetics in the Southeast Asian region, 77 million, which is 87% of total number of people, comes from India. And it is expected that this 77 million would increase to 134.2 million by 2045, which means it is a 74.28% increase. And most interesting, the direct cost of burden of diabetes in India is $7 billion, and diabetes related deaths in India annually is 1.01 million. And over 2 in 3 people have at least one complication related to diabetes. So not only is it important to check this increasing menace of diabetes, it's also important to check the complications and thereby cut the healthcare related expenditure on cost of complications in diabetes. Managing type 2 diabetes and new expectations, we are not only glucocentric anymore. We need to address the basic pathophysiology of diabetes to preserve the beta cell function. The ominous octet, as you all know, is a new poster boy of diabetes pathophysiology. Good reduction in HbA1c, fasting postprandial plasma glucose, minimal risk of hypoglycemia, meaningful weight reduction. The direct trial has shown us that meaningful weight reduction can achieve even remission of diabetes going into the 6th year of diabetes. Proven cardiovascular efficacy, since the major cause of death in diabetes is cardiovascular death, MACE reduction, CV death reduction, and all-cause death reduction have come into the forefront. And we need to also have a drug which can be used in wide variety of comorbidities, renal and hepatic impairment with tolerable amount of side effects. The age of 360-degree care requires a therapy with vasculoglucocentric approach with complete metabolic care. So managing type 2 diabetes, the new expectations, would we want glycemic efficacy, weight reduction, cardiovascular efficacy, renal efficacy, and beta cell function? If you look at Michael Knock's paper in the therapeutic advances with GLP-1 RAs, it is seen that with infusion of native human GLP, which is shown by this red line, vis-a-vis placebo, what happens to glucose? The glucose level seems to comes down, and when the glucose levels come to reach the baseline, it is seen that the insulin levels also, they tend to come down, although GLP-1 receptor agonist infusion is on. And at this point of time, glucagon levels are also seen to go up. So the net result is also the insulin level comes down or the glucagon level goes up. We see that there is a decrease, a progressive decrease in the glucose levels with GLP-1 RA infusion without hypoglycemia, because of the decrease of insulin and the increase of glucagon as the glucose levels touch the baseline. So GLP-1 normalizes glucose levels in patients with poorly controlled type 2 diabetes without inducing hypoglycemia. And if you compare the normal and overweight or obese BMI Asian, if we looked at the literature, we saw 3,119 search. 20 trials were included in the meta-analysis. And this 20 trials included 3,281 individuals in GLP-1 RA and 2,510 in control group. So HbA1c, mean difference in percentage favors GLP-1 RAs, less than 7% target achievement also favors GLP-1 RAs, and HbA1c, if you go by the AAC guidelines, at 6.5, the target achievements also favor GLP-1 RAs. So these can be considered as an optimal choice for Asian type 2 diabetes with even normal BMI for achieving good glycemic control. Liraglutide is a global trial with Indian participation conducted in primary care settings in 9 diverse countries, and 207 subjects, that's 10.4% of the study population, was from India. Almost 90% patients in the comparator arm received either SGLT2 inhibitors or DPP4 inhibitors as dual therapy along with metformin. And in liraglutide, we saw that the liraglutide arm, the percentage of patients who reached a target A1C of less than 65 was higher with liraglutide than with OADs. HbA1c without weight gain was also more with liraglutide in comparison to the OAD arm, and these differences were statistically significant. HbA1c reduction to less than 7% without severe or blood glucose confirmed symptomatic hypoglycemia was also statistically significantly higher in liraglutide arm rather than the OAD arm, and also without severe or blood glucose confirmed symptomatic hypoglycemia as well as without body weight gain was also significantly higher in the liraglutide arm. So liraglutide achieved target without weight gain and without hypoglycemic episodes. Significantly, more patients on liraglutide thus achieved glycemic targets and composite glycemic target versus OADs. Managing the type 2 diabetes, GLP-1 increases satiety and reduced appetite, cravings, and improved control of eating. And it also reduced energy intake and reduced body weight also. If you look at all these trials with GLP-1 RAs, you would see that GLP-1 RAs reduce body weight. And if you see that amongst this in the earlier years, there was a liraglutide, which was the leader. And when in Michael Knock study, you saw that semaglutide 1.6 overscored liraglutide. And if you look out here, you would see against exenatide, semaglutide 1 milligram also had a statistically significant p-value. When you compared the intra-group of the GLP-1 RAs, one against the other in different trials, although the trial populations and the baseline were different. If you looked at this comparator, you would see that initially it was liraglutide which was taking the lead, but then here you saw that semaglutide 1.6 quite outscored liraglutide. And here you saw that 1 milligram of one semaglutide, well, it also did in SUSTAIN 3 outscore exenatide extended release. GLP-1 RAs, if you looked at the molecular weight and impact on weight reduction, you would see that exenatide, lixisenatide, liraglutide, semaglutide, exenatide ER, these are having a comparatively low molecular weight, kilodaltons 4.2 to 4.9, 3.8 to 4.9, whereas dulaglutide and albiglutide are larger molecules, and it's postulated that GLP RAs with large molecular size do not cross the blood-brain barrier and may not access satiety center, thus show less weight benefit in clinical studies. Leading the quest for ideal anti-diabetes therapy, if you look at the leader, the SUSTAIN 6, the PIONEER 6, the REWIND, Harmony Outcomes, EXCEL, and ELIXIR trial, these are the cardiovascular outcome trials involving the GLP-1 RAs. You would look at the PIONEER 6 semaglutide oral trial, where it had a MACE reduction of 21%, cardiovascular death reduction of 51%, and 49% of all-cause mortality. But this risk reduction was only for non-inferiority. If you looked at the REWIND trial, it had a 12% reduction of MACE, but non-significant reduction in cardiovascular death and all-cause mortality. However, in the leader trial, liraglutide definitely did show a reduction, statistically significant reduction in cardiovascular death and all-cause mortality. Liraglutide improved infarct size and left ventricular ejection fraction after ST elevation MI. If you look at this group, this is the liraglutide group versus the control group. If you looked at the final infarct mass, well, it is p-value is 0.05. Final infarct size, statistically significant, p-value less than 0.01. And LVEF at 3 months, well, 0.008 was the p-value. So, well, similar results were still seen in non-STEMI patients also. Estimated treatment difference was 4.7% at a confidence interval of 0.9 to 9.2. So myocardial salvage index, infarct size, and left ventricular ejection fraction in ST elevation MI was significantly improved with the GLP-1 RA therapy. If you look at the renal outcome benefits, that's another organ which is targeted by diabetes, you would see that the composite outcome was 22% reduction of microalbuminuria, new onset persistent microalbuminuria reduction by 26%, and a MACE reduction of 31% with liraglutide. So along with glycemic benefits, liraglutide did significantly reduce new onset persistent microalbuminuria and significant MACE reduction in type 2 diabetes with eGFR below 60 ml per minute. And if you look at GLP-1 RAs, as we saw that diabetic kidney disease is present in 25 out of 100 diabetic subjects, you would see that you could use the GLP-1 RAs to about 15 of eGFR, but less than 15, it's not approved. Whereas if you look at insulin, it is true and true. But if you look at SGLT2 in some countries only, you can use it between 45 and 30, nowhere between 30 and 15. So deep down into the eGFR pool, you have GLP-1 RAs to assist you in continuing therapy for diabetes. If you looked at GLP-1 RA and improvement of beta cell function mechanism in type 2 diabetes patients, it increased secretory capacity, increased beta cell function, beta cell glucose sensitivity, decreased the pro-insulin ratio and first phase of insulin secretion. And in vitro, you got the beta cell apoptosis, which was decreased. And in animals, you saw the increase in beta cell mass. So the quest for the ideal anti-diabetic drug for glucovasculometabolic benefits, well, it would reduce the HbA1c fasting and postprandial glucose, minimal hypoglycemia, decrease the weight, give cardiovascular benefits, and with a tolerable side effect profile, and should be approved for a wide variety of patients. Capture study gave an alarming signal which showed that it is time to roll up our sleeve. The study found that 1 out of 3 people with type 2 diabetes have established cardiovascular disease. 9 out of 10 people with type 2 diabetes and established cardiovascular disease have atherosclerotic cardiovascular disease. 2 out of 10 of these patients with type 2 diabetes get a glucose lowering treatment with a proven cardiovascular benefit, and professional cardiology and diabetes organizations have recommended GLP-1 receptor agonists as a preferred therapy for people with type 2 diabetes and atherosclerotic disease. The challenge. Till now, it was said that the first injectable can be GLP-1 RA instead of basal insulin. Fear of injections may still remain a barrier to the use of GLP-1 RA in both patients and physicians. A global internet survey of 1,250 physicians reported having too many injections is associated with poor adherence to treatment in patients, and 26% did agree. Trypanophobia is the fear of needles, and it is present in adolescents about 63 to 75%, and in adults in about 20 to 30%. That means 1 out of every 3 patients suffer from the morbid fear of needle spins and other sharp objects. So there is an innovation which has come, which may help us to overcome this. That's oral semaglutide, a new route of administration for GLP-1 receptor agonists, possible with an absorption enhancer. Bioavailability is low and variability is absorption being higher. It is mitigated by a 1-week half-life and once daily dosing, several treatment doses, and patient compliance with dosing conditions. These are the trials, the pioneer group of trials. Pioneer 1, the oral semaglutide was tested versus placebo. Well, as an add-on to OAD, you had Pioneer 2 versus SGLT2 inhibitor, Pioneer 3 versus DPP4 inhibitor, Pioneer 4 versus GLP-1 RA and placebo, Pioneer 7 flexible dose adjustment versus DPP4 inhibitor with extension. Pioneer 8 was add-on to insulin and it had 51 Indian subjects. Pioneer 5 was in renal impairment. Pioneer 6 was the cardiovascular outcome trial and included 201 Indian subjects. The glycemic control with oral semaglutide versus comparators. This is the low dose Sema 3 milligram. This is the 7 milligram, and this is the 14 milligram. Only you have seen the change in HbA1c everywhere. Sema scored over the comparators. That is shown in the single slide in the Pioneer group of studies, and this is achieving glycemic targets. Also higher proportions did achieve glycemic target, and obviously as expected, lower dose of Sema did less well than the higher dose, and the 14 milligram dose had superseded even liraglutide in the percentage of patients who achieved glycemic goal of less than 7%. And if you look at change in body weight, well, only EMPA 25 did come near to Sema 14 milligram, whereas others, comparators, you had, well, the 14 milligram of Sema scoring over the comparators against which it was pitched in the Pioneer group of trials. So this is the cardiovascular outcome trials, hazard ratio 0.79 for MACE, that this is the time to first occurrence of CV death, non-fatal MI or non-fatal stroke. And this is the placebo, and this is the oral semaglutide p-value, less than 0.001 for non-inferiority, but the upper bound of the confidence interval topping the 1 mark p-value was 0.17 for superiority. So what did we get from Pioneer 6? We got that HbA1c and body weight was significantly reduced versus placebo. Overall adverse event profile similar to other GLP-1 receptor agonists, and 21% non-significant risk reduction versus placebo. So in the result of Pioneer 6, which was designed to evaluate CV safety, we see that the peptide innovation for early diabetes treatment 6, that's the Pioneer 6 cardiovascular safety trial of oral semaglutide as GLP-1 receptor agonist, did demonstrate adequate cardiovascular safety with a hazard ratio of 0.79 and a strong signal for reduction of cardiovascular mortality rate with a hazard ratio of 0.49. So in conclusion, we can say that this oral drug can be used as a safe alternative and with the benefits of GLP-1 receptor agonists in times to come when it becomes available in India. Thank you so much for your patient hearing, and I would be open to questions if any.
No issue.